Fine. Can everyone see that?
Yep.
Brilliant. So yeah, hopefully all of you know me, but I'm Tom, one of the CESA trainees. So I was just going to do a session today, just going through about sort of pediatric DKA. So my grand plan is we're going to do a little bit about sort of the epidemiology, sort of some of the basic science, but just touch on that. Going to mainly sort of focus on the sort of the management and just how we sort of go slightly different from sort of adults, because it's quite different in how we do it from that side. So in the UK, so about 36,000 or so children do have type 1 diabetes. The incidence is about 25 per 100,000. So in our sort of catchment area for sort of the Doncaster borough, that means there's probably going to be about 75 new diabetic type 1 cases a year. And they say that sort of roughly 20% of those will present as DKA for their first presentation. So it's not something that we'd see that often. So sort of 20% of 75. So we're going to be looking at sort of one to two a month from that side. So it's something that's, you know, not common, but is quite important to know a bit about from the sort of initial start and treatment. There's normally sort of two peaks when you'll get the presentations of kids coming in. So the first one is sort of early childhood, so sort of 6 months to 5 years. And then you get sort of a later peak in puberty, with sort of most of them coming in that sort of 10 to 14 age category. From that side is your most common age for presentation. I think you also do get a slight variation throughout the year, so they're not evenly spread. So I think it's sort of autumn time, you do get a slight peak. And I'm not entirely sure whether that's just because they're sort of getting infections as a bit of a trigger from that side, and sort of setting it off. Fine. So just going on to science stuff. So I'm only going to touch lightly on this because I think most of us sort of know a little bit more about the background from a diabetes point. So type 1 diabetes, which is the main one we're focusing on, because that's the ones that put you into DKA. So it's an autoimmune condition that is sort of a progressive destruction of your pancreatic beta cells. And this just leads to a progressive failure of insulin production. And it will sort of progress slightly. So initially with your children, when they're sort of first diagnosed, they may have what's called a honeymoon period, where they'll still have some of their own insulin production, and they may be able to get away with missing doses more than, you know, once they're sort of fully established and they have that none of that inbuilt production. The lack of insulin then just leads to a bit of a runaway process. So you get the gluconeogenesis, glycogenolysis, you get decreased uptake from the tissues, and you get the lipolysis. The high glucose is what leads to the osmotic symptoms and causes the dehydration, and the high ketones is what leads to the acidosis. So presentation wise, so we've all sort of read the textbooks and probably seen a few of these sort of come through the door. So on the left is sort of more, you know, what you might find symptom wise, and sort of get a history. Often sort of your first presentations, you know, when sort of speaking to parents, they've sort of noticed some of these, but so it's particularly drinking lots, but they often just sort of attribute it to things like sort of hot weather, and they've sort of put it off. So they then sort of come in a little bit sort of surprised with everything that's going on. Things on the right are bits you might sort of pick up from your sort of examination or sort of notice from that side. Whenever they've presenting in sort of a DKA situation, always sort of think about what's caused it to happen now, because they may have been sort of running high with their sugars for a while. So it's just if anything particular has happened that's sort of pushed them into it, such as things like infections as well. So diagnostic criteria. So the main ones are, so the pH of less than 7.3 or a bicarbonate of less than 15, and their blood ketones above 3. So blood sugars will normally be high, but not always from that side. So just it's one of those just to not be caught out of if their sugars are normal. So other things to sort of consider when you're sort of seeing a kid come in who's, you know, high sugars. whether it's hyperosmolar, hyperglycemic state. So in those, you typically find the blood sugars can be very high, so potentially over 35. You might not have the ketosis either. You wouldn't expect them to be acidotic. You can get euglycemic DKA, so that's one to just be careful of from that side. So either they've had some partial treatment or their sugars aren't that high. So just need to be aware of that if you're sort of finding these other features that would sort of be consistent with it, but just not the high sugars. And then the final one would be whether they're actually coming in just with sort of a new presentation and they're not actually in DKA, but they're just sort of running the high sugars. So again, in that you would expect raised sugars, but you wouldn't have that acidosis or the ketones present from that side. So sort of more going on to sort of management bits, because with us, we obviously aren't going to be managing them as long as we would for adults. So they may stay down in the department for a while, but generally with these, we'd sort of get pediatrics involved. So my main focus is going to be on that initial management of the first few hours. So our aims, so what we want to do is correct the fluid deficit. So often due to the osmotic symptoms, they will be quite dry and have got progressively dehydrated over the sort of preceding sort of couple of days. We also want to resolve the ketosis and control the blood sugars. The idea is if once you can get the ketones to settle there, what's causing the acidotic feature from the ketone bodies. So the idea is to drive those down, which is why we will continue their insulin when we're switching them to glucose to sort of really get the ketones settled. Whilst we're trying to do these, we're trying to prevent any sort of ongoing side effects. So things we'd be wanting to avoid are cerebral edema, hypokalemia, and hypoglycemia. So these are just based on sort of following sort of standard protocol and just making sure we keep an eye out for all these bits as they happen. Then finally, sort of if there's a low GCS, we just need to make sure that the risk of things like aspiration are sort of accounted for. Fine. So management. So it differs from adults in how we treat. So particularly they're sort of quite restricted in fluid resuscitation. So in adults, as you know, we sort of give them loads of fluid very quickly and aggressively. But before sort of 2020, a child presenting in DK would actually get less fluids than a child who was just on maintenance because of the risk of cerebral edema and the worries from that side. With the recent updates in 2020 and 2021, actually is a lot more liberal in how we can give fluids. There's a delay in starting insulin, so we wouldn't give the bolus dose of sort of 10 units or anything like that. We'll put off insulin for at least an hour or so before starting. We grade the severity based on the pH, and I'll go through that in a little bit more detail. We've actually got quite a good performer for it, so I don't know if any of you have seen it, but it's quite an easy one to follow. It sort of tells you all the bits to be thinking about. So any patients, I'd always get that out for. If you're somewhere that you don't have our performer, so there's a British Society of Paediatric Endocrinologists and Diabetic people who have quite a good guideline, and actually theirs is a little bit more update than our current one at the moment. So I'd use our one generally because it's our trust-based one. But if you can't find it, there's none in the department, you can't get hold of one or you're somewhere else, then that you can find on the internet and is very good as well. Fine. So sort of initial management wise, so they're sort of focused just for this on sort of the bits we need to get done and sort of where to do them. So I generally say for all these, you probably want them in recess because they're often quite poorly, and if they're not too bad, they do have the potential to deteriorate once you do start treatment. I'd always get sort of senior input, and sort of paediatricians are always quite happy to come down early for any of the DKA patients. You want sort of access for them, so I'd initially go for sort of one access, and then we can always look at a second one sort of later on from that side. But when we're getting it, sort of access and bloods off, most important thing would be sort of getting the gas off, because that will help us confirm the diagnosis. Then we also need to think about sort of things like baseline UNEs. So for a new diagnosis one, there's a load of sort of bloods that they'd want doing. So things like your HbA1c, things like sort of insulin, C-peptide, and bits like that. So generally, from our trust, you'd need to send off a purple, a grey, and 4 golds. The gold will go to external labs, so that's why you need 4 of them from that side. So the actual volume of blood you could probably get away with, but because they go to externally to get that. If you can't get them or they're not bleeding, then that's okay, because we'll have plenty of time to jab them later to get more off. So I'd say first thing is you want the gas, because that will at least confirm your diagnosis. If you move them across, just while you're getting all this done, just pop them on some oxygen. If you can get a weight for them, it will be useful later on for just working through your calculations and then seeing if you can find the Proform to get that started, because it's quite useful for a memory prompt. So IV access wise, so I've just got on the left here. So these are the Gelco cannulas that they have for pediatrics. So the difference is that they don't have wings. So they're a little bit more fiddly. So it's worth having a little look about them. So yellow ones are generally for less than 1 year. Blue ones sort of do most of your general kids. I think if you're going to go for pink, you might as well put one of our normal cannulas in, because they're a little bit more familiar from that side. If you're struggling for access, what I've got in the picture in the middle is an AccuVein. So they'll have these on the peds ward. So if you're speaking to the pediatricians and access is looking like it's tricky or we're struggling, if you let them know, they'll bring down an AccuVein, which is like the pediatric equivalent of an ultrasound for getting access. And it just means that we can sort of speed things up. And then finally, if we are struggling, if we can just get a capillary gas off, then that at least allows us to sort of confirm the diagnosis. So if you've not done them before, normally the peds nurses can do them. If you're doing them yourselves, just make sure there's no air bubbles in the tube, because that will just stop them from going through the machine and you'll have to repeat it. So severity of DKA. So this basically guides what we do for sort of treatment and sort of fluids sort of longer term. So we class mild as sort of a pH of 7.2 to 7.29, or a bicarbonate of less than 15. Moderate 7.1 to 7.19, and a bicarbonate of less than 10. So it can be sort of either or. So I generally put them in the more severe category if you've got one thing of one and one thing of the other. So I go for sort of the more severe. And then sort of severe is pH of less than 7.1, or a bicarb of less than 5. And for sort of calculating fluids, so our protocol suggests, so mild we assume a 5% dehydration, moderate a 7%, and severe is a 10%. Although the recent updates on the base bed sort of now treat mild and moderate as both 5% rather than 5 and 7. So then, so the first decision, so obviously sort of got them in resus, gained your access, got your gas off and confirmed your diagnosis, which is brilliant. So then your sort of first decision about management wise is to assess if they're shocked. So the features that we'd be looking for, sort of tachycardic, delayed cap refill, weak pulses. If you're getting to the point of hypertension in the child, it's a very late sign. So they'll maintain their blood pressure right up into their sort of almost peri-arrest. So it's sort of assessing these together and sort of making a decision if you think they're shocked or not. So if we're concerned that they are shocked, what we need to do is to give a fluid bolus. Sort of what we'd sort of suggest is a 10 ml per kilo bolus of normal saline over 15 minutes and reassess. Our guideline does suggest 20 mils per kilo, but it'd be better to give it in smaller aliquots, and then sort of can basically reassess and give more if needed. If they're not shocked and you think they're otherwise sort of okay, then all of them will get a 10 ml per kilo bolus sort of anyway, but it'd just be given over an hour instead of 15 minutes. Fine. So I've just got a picture here. So this is our sort of resus here from PED side. So obviously we've got our notice board, and you can see just where that big arrow is, that's where we normally keep our Performer. And this here on the right is just what it looks like. So it's quite busy on there, but it's relatively straightforward. So you can work your way through that, and it just gives you any prompts that you need and just important bits to assess as you're going along. This is a sort of next page. So it's just sort of going through about sort of shocked or not shocked patients, and it's just where you sort of document as you go. From a bolus, so it does say there, you know, from a weight point of view, because obviously you're doing 10 kilo. Here it says 80 kilos as your maximum for a child, but they've reduced that now to 75. So the maximum bolus you should be doing is 750 mils, which is still quite a lot for a kid. On that side. And then the rest just goes through working out sort of your fluid as you're sort of ongoing. So all your kids come in, we've sort of confirmed the diagnosis, let paediatrics know from that side. We've given them the fluid bolus either as they're shocked or not shocked. And then after that has gone through, we need to then look at ongoing fluids. Hopefully by this point, you might have the paediatricians down, which case they'll take over all this and sort it out. If not, if they're sort of tied up somewhere, then we'll probably need to start these fluids ongoing. So they are prone to errors. So whenever I've seen people do this, you always need someone to second check it, because it's quite a lot of calculations, and there's been quite a few times where I've seen people go wrong on these, and it just creates a little bit of faff later on. And basically, the idea is that we work out how much sort of fluid deficit they've got, and that's just going back to sort of the severity, so either 5 or 10%, and working that out as sort of a volume. We sort of replace that over 48 hours rather than acutely sort of in the first 24, just because that reduces the risk of going into cerebral edema. If they are sort of if they weren't shocked, we would sort of take that bolus off that total sort of deficit, just so we don't give them too much fluids. It's one of these ones that is best just to work through the Performer, and sort of if you look there on the right, you can see it's basically sort of got all the different bits of calculations, and it sort of follows through quite nicely with colours to allow you to work through. I generally try and do this a little bit away from patient, just so that then you can get that little bit of time just to make sure you get it all right. After the initial sort of bolus, then we put them on sort of normal saline with potassium, because we know there's a risk of them dropping their potassium levels as we start to introduce insulin and treat them. So the only times you wouldn't put potassium in any fluids would be if they're hyperkalemic, so that's basically anything above our upper normal limit, if they've got ECG changes, or if we think they might be anuric. Obviously, we won't know exactly if they're going to pass urine or not, but generally sort of it's a little bit of clinical judgment there. So most people will get the potassium, but just a few things to consider before we do give it. Fine. So we've continued our sort of fluids going through, we've given our boluses, then it's sort of looking at starting insulin. So insulin, we always start that after an hour of fluid resuscitation. If you give it earlier than that, there's been linked with that increase in your risk of developing cerebral edema. So starting rate is at 0.05 or 0.1 units per kilo per hour. In most cases, we'll go for 0.05. And the times you'd consider going for a higher sort of initial rate would be sort of the adolescents, so when they're sort of approaching adult age, or sometimes in sort of the more severe decays, you might do that. But generally, I'd go for 0.05. So once we've got all the sort of initial bits in, so we've got our fluids running, we've got our insulin up from that side. Hopefully paediatricians will come down and sort of start to take over from this point. But things we just need to be aware of is at 2 hours after sort of treatment, they'll need just a recheck of their UNEs, blood gas and ketones. And that will just allow us to assess how we're getting on sort of treatment wise. We probably wouldn't expect to see huge changes, but just to ensure we're sort of not causing any problems such as pushing them hyper or anything. So once blood sugar starts to drop and hits less than 14, that's when we'll start to add dextrose to the fluid. So they end up with dex saline sort of running from that point with the potassium in it still. All of these kids will need to go to HDU as a minimum, just from a monitoring point of view. So just given that they have the regular blood sugar monitoring and it's sort of a more of a nursing input once they're starting to stabilise. So if you're at Bassetlaw, they're going to have to be transferred. If you're at Doncaster, hopefully we should have beds. And normally they're quite good for sort of moving them around on the wards to make space for these, if not. So kids to worry about. So most of them will probably be sort of all right, and they're ones that you can sort of correct quite quickly. The times to be sort of concerned are the ones that have potential to deteriorate. So reduced level of consciousness on attendance. So if they're sort of drowsy or a little bit strange, these are the ones I've seen that sort of go off and potentially will deteriorate. So the more severe the decay, sort of the greater risk that they can develop complications, and particularly sort of the young children with a new diagnosis. So less than 2 will just generally have a bit more of a severe disease. And the new diagnoses will probably present a little bit later than the children who have diabetes and just are starting to run high, purely because from a monitoring point of view, you'd hope that your known diabetics would pick up their sugars are going up. So cerebral edema. So I was just going to go through this a little bit. So this is the sort of main complication that we worry about in DK from that side. So it's not sort of fully understood exactly about who will develop it and or why they get it. But generally it's thought to be due to an osmolar gradient. So as you correct the blood sugar, the osmotic potential from that goes down as the sugars start to improve. And that basically causes a concentration gradient, which then causes a shift of fluid and gets the cerebral edema. When it does develop, it has got quite a high mortality, so 20 to 50%. And, you know, in kids, that's something that, you know, which we do worry about quite a bit. So treatment-wise, so with these, it's always sort of escalate early because these have got the potential just to continue dropping their GCS. So treatment-wise, so hypertonic saline would be first line, so 2.7 or 3%, and give 5 mils per kilo over 15 minutes. If you've got the Proforma, it's all in there, so you know, don't expect to remember any of this, but just know that it's all be there to use if needed. If you can't get hold of the hypertonic saline, then you can give mannitol at 2.5 mils per kilo over 20%. You'll want to slow their fluids down, so the rest of their sort of maintenance and sort of correcting their deficit. It's advisable then, if you're at that point of view, to sort of get intensive care involved, because if we've got a fall in GCS or sort of the headaches, confusion, agitation, then whether they're going to end up being tubed for either transfer or going around for CT. The CT is more just to exclude any other pathology, because as we mentioned earlier, sort of triggers could be things like infection or anything else going on. So it's just looking at excluding any other diagnoses about what's causing the drop in the GCS. From that side, I've seen a few where they've had sort of issues and they've been concerned from cerebral edema points, and generally these are the ones where they've come in as a more severe DK, so sort of pH is less than 7, and who already sort of had a little bit of a fluctuating GCS on first presentation. So that's why just they're the ones to be a little bit worried about. Other bits just that I'd say just to be aware of and sort of note. So with our guidelines, there's a discrepancy between sort of the up-to-date ones and what we've got. And, you know, I don't think they'll make a huge difference in what we get outcome-wise, but I think it'd be worth just being aware of them, because you might find that when the paediatricians come down, if they're working on a slightly different guideline, that it might just change things slightly and get different calculations from fluids, which is okay. Insulin pumps, so if they do have one, it's best to turn them off, because obviously whatever reason they've got going into DK, their pump's obviously not working adequately enough. And what we don't want to do is get varying levels of insulin going in that we can't control initially. Any long-acting insulin that they're on, we'd want to continue, just because that will enable them to come off the sort of variable rate oscillator scale later on a bit easier. So 16 to 18-year-olds are a little bit of a grey area. So we can go either way on them, and it depends a little bit on our clinical judgment. So generally, if they're under 18 but over 16, and they're known to pediatrics and haven't been transitioned, they'll go under pediatrics. If we're going to send them to peds, we probably need to treat them on the peds pathway, just as when I've spoken to a few of my friends as registrars from Peds Point, if they've been treated as adults, they don't really know where to go because they're not familiar with that. From that point, fine. And then finally, that's just a link there. So if you know, when the slides come on, if you have a little look through or just type into Google, you can have a little look at their DKA proforma. It's very similar to ours, but sort of seems almost a little bit more user-friendly from that side. So I would recommend having a look through, just so we know where we are from that point. So I think that's pretty much sort of most of it sort of going through quickly. So the main things are sort of getting the diagnosis confirmed early, sort of escalating to pediatrics and sort of seniors quickly. Sort of initially starting with the fluid sort of bolus as treatment, and then delaying sort of starting the insulin after they've had that hour's worth of fluid going through from that point. Fine, I think that's pretty much it. Anyone got any questions? Or
Tom, can you explain a little bit about this cerebral edema due to the gradient, osmolar gradient of the treatment?
so treatment wise, yeah, so basically you've got sort of two options in with regards to treatment. So
no, Tom, the cause for it, that the first line you said about the osmolar gradient due to treatment.
Yeah. So they think it's with the osmolar gradient. So what they think is that obviously when you've got sugar anywhere, it will basically sort of suck water towards it. So that's sort of what, when we're trying to reduce like paraphimosis, we put the 50% dextrose on to sort of suck the fluid out. So when they've been at home in sort of before coming in, and their sugars have been sort of high 20s, that will sort of diffuse across. So intracranially, sort of in the brain tissue, their blood sugars will be about 20 or sort of plus really. They also think there might be an element of a sort of protective factor, which basically ensures that they get good perfusion to the brain and sort of good sort of water delivery to the brain as well, which they're not sure what causes it. But basically it's in sort of a situation where it's coping with having to sort of draw more water to itself to sort of keep ticking over. Then when your sort of free water increases and your osmolarity in your sort of serum drops, it basically creates a diffusion gradient. So before you'd be sort of in an equilibrium between your serum and your sort of intracranial tissue. And then what you find is as your blood sugar drops down, the water will move from your serum into your tissues, and that will get sort of a cerebral edema and sort of develop that swelling.
Yeah, I think the other thing is like we have a concept of autoregulation in different organs, and the brain also have got autoregulation mechanism. I think the autoregulation happen in the blood pressure of 60 to 160. I'm not sure about peds how much the blood pressure range, but in adult 160 to 160. So once the blood pressure is on these both extremes, below or above, then the auto-regulation is disturbed. And there's a concept of cerebral perfusion pressure as well. So the cerebral perfusion pressure is what they call mean blood pressure minus by the intracranial pressure. So the mean blood pressure, remember, is calculated as systolic blood pressure plus twice the diastolic and divided by, I think, 3. And then, that's the mean arterial pressure, then to minus the intracranial pressure, which is about 13 or something. And that gives you figures, which you can see whether the auto-regulation has disturbed or not. So once the auto-regulation is disturbed, either very low blood pressure, very high blood pressure, then the chances of cerebral edema developing increase. And also, Tom is saying is a major part is played by the the osmolar gradient as well. Hence, insulin is not given in kids, early on. So we wait for the treatment for 1 hour because the main function of insulin is to push glucose into the cells. So once the glucose is pushed in the cells, so the cell osmolarity will be apparently more, and will suck the fluid. The cell will suck the fluid, they swell up and cause all the trouble. I think there's no definite answer to that, but these two mechanisms can explain more fluid in the brain and causing cerebral edema. I mean in our trust, we didn't have this pathway until I think was about couple of years ago, when Amjad was our CD, and then we started looking into the pathways. We set up MyED, and then there was email forth and back from the pediatric. So we have a considerable painstaking experience in setting up the DK protocol. I think is good, apart from these a few differences, the local differences. And Tom is absolutely right. We need to involve pediatric because the fluid calculation and the DK management children quite different than adults. And the more fluid in lead to cerebral edema, which is quite nasty and a fatal condition. I think, Peter, it was a very good presentation and relevant to the department. I think I like that idea that, you have gone to the resource and took pictures and done a research, what is resources available currently in our department. I think that's very, very good touch, very practical touch. Yeah, well done, Tom. Thank you very much for this nice presentation.
Thank you.
Okay, thank you, Tom. So if we don't have any questions, so we can end the meeting here.
Yeah, one thing, Sundar, yeah, you are a good moderator. You've done a good job, believe me, So well done. Yeah, we must appreciate that one as well. And, that's precisely this program is about, getting skills and, non-technical skills, because, we're all doctors, so being doctor, we are doctors, but that thing make difference really. So well done. Everybody should come forth and do this sort of presentation and moderation and stuff like that, And, I mean, it's amazing, Tom presentation, absolutely amazing. It's really impressive stuff happening. Oh, we are making history, guys. I can tell you that. Well done, guys.
Okay, thank you, man.